I wish a very happy new year to the listeners, both physically and online platform. Uh, so first, I would like to thank President KSM, Joint Secretaries and Council for inviting me to deliver this talk as the first CME session and organized by the KSM. So without wasting much time, we will straight away go into the topic, that is understanding a lethal triad, resuscitation of trauma in emergency departments. To give you some insight on what sort of things happening in emergency units with regard to trauma, though this case is not directly related to the today's topic, I will give you a case where this has a lot of positive things for us to gain to manage a trauma. So we had this patient very recently, last week, in and around 7 o'clock in the morning. We got a 73-year-old female presented with slipped and fallen in a bathroom. So 1 hour ago. And we found that the patient is on warfarin. On admission, apart from GCS of 14 and periorbital hematoma, patient was stable. So the FAST was done. There was nothing much significant, and the secondary survey was again, apart from the signs of head injury, unremarkable. So we were thinking we need a CT brain, so we ordered a CT brain. The CT brain was done, and after about 15 minutes, when the patient is like arriving from the CT, we noticed that the patient is having a bit of respiratory distress and found out that patient is developing a stridor. So at this moment, we had to call for help, started the trauma team, get we have to call the other specialties like ENTs, neurosurgery, and then start resuscitation. So we found out from the ABCD assessment, the airway is at threat. So we prepared our difficult airway kit, but we planned for the intubation because the saturation was dropping in spite of doing all this, trying to giving the oxygen. So we will end up with can't intubate and can't ventilate situation where saturation dropped, patient went into cardiac arrest. So as we have called the team, so we started CPR, continue our management, and then we have to get the front neck access to enter into the trachea. So we did it successfully within next 6, 7 or 3 cycles, and successfully we were getting the return of spontaneous circulation. And then, so we had to stabilize the patient. So we have to reverse the warfarin, and we had to get the surgical inputs. And then patient had some arrhythmia, so we had to get the other opinion. Once we stabilize, we had to transfer this patient to ICU. So this case teaches a lot of things with regard to trauma resuscitation. So it's a very common presentation to ED setup where we receive this sort of patients daily basis. And then to manage these patients, we have to have a very good communication. When it comes to road traffic accidents, so you need to get the information from site of injury to the hospital. So the pre-hospital care is also important in that case. Once we get the patient here, we need to communicate well within the team and to the outside of the teams. If we are transferring this patient to another facility, we might have to continue that part as well. And also, you have noticed from that case, this is time critical. So sometimes patient is stable, but when it comes to the emergency, the time is the barrier that you have. So you need to act on time to prevent that death or the morbidity. And also, you have seen we need support. So managing a trauma, there are no individual heroes. It's a collective decision, and it's a combined decision from different specialties. Mainly, when it comes to like trauma, mainly most of the surgical specialties come into play and make their decision to make the patient to prevent the patient's morbidity or mortality, and you have to have very good coordination with the teams as well. Once you stabilize, again you need to coordinate a dispatch. Just you cannot put the patient into a ward. You need to talk to the critical care teams, arrange ICUs, or whether the patient is going to a theater or to the ward. That should be a coordinated dispatch. And above all, managing trauma is exciting. And people who have managed trauma know, like, sometimes it's very stressful because you will find unexpected things happening. As in this case, we never suspected patient to develop airway trauma, airway injuries in a patient who had evidence of mild head injury on presentation. So it's exciting, stressful, and sometimes dreadful as well. Right, so keeping in this mind, we will talk about trauma and its burden initially. According to the 2017 annual health bulletin, about 1 million people are getting admitted per year due to trauma. And out of which, the majority are fallen into the productive age group, like 15 to 44. That is an economic burden as well to a country. And it's amount to like 20% of total admissions to the hospital. And then according to this bulletin, it mentioned there are about 14,000 deaths. So the significant thing is, out of these 14,000, 10,000 deaths has happened before even reaching to the hospital. So there are a lot of things that we can do. And so, as I said, most of these trauma are preventable. So the prevention has different aspects. One thing is we can do preventive measures, like starting from wearing seat belts, wearing proper helmets, and then you can, from the legislations, we can like have the speed limits, car safeties, and so on and so forth can apply. But most of these deaths are preventable, that we also have a part to prevent this these deaths happening. So nothing is more exciting than a little bit of history. The trauma care has been haphazard until late 1970s. So there was a very tragic incident happened to one of the orthopedic surgeons in the United States, where he had a lucrative lifestyle those days. He owned a private jet. When he was flying on that, he had a crash, and then his wife died on the spot, and his 3 children got critically ill. And he has seen himself the way that rural hospital with low facilities treated their own children. He had felt there should be some method to treat these patients and finding the prioritizing their victims' injuries and to treat. So this developed into today's ATLS, where now it's widely accepted and available in most of the countries, where it treats standard way even you have like low resource settings in your departments. And also I will introduce one of the other important thing is trauma team. So this comes in like when it comes to a medical emergency, we talk about the resuscitation team, a rest team, but when it comes to a trauma, it's a trauma team. So this has a team leader and designated jobs for each member of the team, where these jobs are designated when it comes to the shift, like 8 a.m. in the morning. When you are accepting the role in the morning, you accept the role as well. So when it comes to a trauma, no one wants to say go to the airway, go to circulation, because they know what role they have. And then there are team dynamics, there are ways in which communication happens, and then there are ways in which you have to communicate with the team leader, and team leader will communicate with the other specialities and the other systems. So this is a very important concept that I need to highlight. Wherever you are handling trauma, we need to have the trauma team led by the team leader and their allocated roles for the team members. And so I'm going back again with our annual health bulletin reports. The majority of patients have died before reaching to the hospital. According to this distribution, this is the trimodal death distribution in trauma, where 50% of patients will die before reaching to the medical facility. So that is a huge numbers. And as medical people, we cannot help for these patients. So only the safety measures, applying safety belts, helmets, safety measures in the cars, roads, and legislations can prevent these 50%. But the other 50%, we are accountable. So 30% within minutes to hours will die because of the airway injuries and also blood losses. And then rest of the, or the latter part, is mainly due to blood loss and surgical complications. So proper trauma care systems can minimize this latter part of deaths. And when it comes to trauma, we talk about a time critical emergencies. So when it comes to these times, they are talking about an hour. That is not exactly 60 minutes, but whatever, if you can treat the patient early, so there will be less mortality or morbidity. So going beyond these hours, when it comes to the pre-hospital care or at the site of injury, you can apply. So they are talking about this platinum 10 minutes, where that is the first 10 minutes after arrival of the medical rescue teams. And according to standard protocols, there are two main ways that they handle this trauma in pre-hospital. One is stay and play and the scoop and run. What in our country, with suicide area, we are doing the scoop and run business, where you get the patient and rapidly transfer this patient to the hospital, maintaining the parameters. But in larger countries like Australia, in rural setting, they practice this stay and play, where you need some expertise, where you might need some cannulation, intubation, even blood transfusions, and they do that in rural setting. But still, in urban setting, that countries, they prefer this scoop and run thing, because once you come to the hospital, you can do a lot of other things where pre-hospital care cannot do. So to talk about the concepts, we all know, like, it should be a systematic approach, or it should be according to the ATLS protocol, where we manage A, B, C, D, E. And also, I emphasize the importance of working as a team, and lack of definitive diagnosis or history does not, it will not cause any delay in starting assessment and the treatment. And very importantly, we have to reassess these patients whenever you find there's a problem. So my main topic today will be talking about circulation and its complications, some other things. So I will straight away go into that. So the circulation is assessed very simply by pulse, blood pressures, level of consciousness, and capillary refilling. And when it comes to a trauma patient, if you find this patient's blood pressure is low, you have to exclude hemorrhagic shock. Even though there are a number of other shocks can be present in this patient, like obstructive shock due to tension pneumothorax or cardiac tamponade, or neurogenic shock, or even distributive sort of shocks can be present, but you need to exclude hemorrhagic shock. So I will display this classes of hemorrhagic shock, where we have been looking at this from our medical student ages, but there are very important things we can get. One is, even if you lose about 30% of blood, so as in class 2, your systolic blood pressures will be normal. So normal systolic pressure does not mean this patient is not need any sort of like fluid resuscitation. And also the other thing, when the blood pressure is low, like in class 3, patient has lost about 30 to 40% of blood. So any patient following trauma, and if you see the patient's blood pressure is low, that patient need blood transfusion. So you have to remember that. So when you insert the cannula, take blood for grouping and GT, probably you might need to transfuse blood. And if you cannot find any blood, so if you cannot measure blood pressure, it means probably patient is in class 4. Some people say it's too late, but you have to start your fluid resuscitation and you need blood and blood product transfusion for this patient. So these are some of the numbers. So if you suspect on admission this patient is having a pelvic fracture, probably patient has about 2.5 liters of blood as bleeding. So any patient who's having a pelvic fracture or femur fractures following trauma might need blood transfusion. So you need to, when you put the patient's IV line in, you need to get the blood. So others, according to the other injuries, patient if isolated injuries, you might not need to give blood. So where to look? So these are very simple things. So people would say, so there are like places to actively look for bleeding when you have somebody with low blood pressure, especially chest, abdomen, pelvis, long bones, and if you cannot find anything, you have to look at the ground or floor to see. So when trying to find a bleeding, point of care ultrasound has revolutionized the trauma care, where you can do most of these investigations at the emergency department without transferring these unstable patients to the radiological department. So commonly, the point of care ultrasound commonly we are using in trauma is EFAST, where you assess some of the cavities like chest, abdomen to see whether there's any evidence of free fluid, as well as you can exclude pneumothorax. So if an expert is doing, so these are very sensitive tests where you can exclude or include whether there's any evidence of solid organ damage in trauma. So when it comes to talk about the lethal triad, so when a patient is having severe blood loss, it can cause like coagulopathy, hypothermia, acidosis is developing. So what usually happens is when you lose blood, the blood pressure, low blood pressure causing less tissue perfusion. It can increase the lactic acid causing metabolic acidosis. So when you transfuse normal saline or fluids, so it can lead into hypothermia, and also losing blood can lead into hypothermia. So both acidosis and hypothermia in turn can lead into coagulopathy. But other than this resuscitation associated coagulopathy, there's a different entity which can cause coagulopathy without causing these things. So that is called trauma induced coagulopathy. So we will discuss it further in detail. So to talk about the coagulopathy, that is the main killer in trauma resuscitation or trauma. So if you do not correct the coagulopathy, that will end up with death or mortality or morbidity in trauma. So seen in and around 30 to 50% of severe trauma. So I mentioned this part, the resuscitation associated coagulopathy is due to, like, if you give a lot of crystalloids, it can cause dilution, and also because of the consumption or the cascade is activated, so it will cause consumptive coagulopathy. And also, as I said, the acidosis, hyperthermia can develop this one, causing resuscitation associated coagulopathy. And the other one, the acute traumatic coagulopathy or trauma induced coagulopathy, will be dealt later. So little bit of hypothermia. So when it comes to the hypothermia, it will cause the platelet dysfunctions, and it will cause reduction of enzyme activities, which can lead into coagulopathy. And acidosis, so usually the lactic acidosis will happen because of the inadequate perfusion. And also, if you give a lot of fluids like normal 0.9% normal saline, it can cause hyperchloremic metabolic acidosis. So most of the coagulation factors, especially factor 5, 7, and 10, depend on pH. So if the pH getting acidic pH, the activity of these coagulation factors decrease, and it will cause coagulopathy in this patient. So the acute traumatic coagulopathy, so this has like you probably have seen this in about 60% of patients. Initially they have suspected this. Before any resuscitation, they have found some patients coagulation has altered before even resuscitation. So they have suspected there's some other element which is causing this coagulopathy. So found out that there's a thing called acute traumatic coagulopathy that is due to severe trauma and the release of cytokines as well as low blood pressures. So there are two ways they describe this. One is through mediated through the activated protein C, which has anticoagulant and fibrinolytic activities by inhibiting plasminogen activator factor 1. And also others think that is activated through a disseminated intravascular coagulation sort of phenomenon. So everything together, the trauma-associated coagulopathies, trauma-induced coagulopathy plus resuscitation-associated coagulopathy, that is acidosis, hypothermia, dilution, and consumption. So that is the main problem. So in our resuscitation, we try to minimize this part because that is the killer. Right, how to minimize the trauma-associated coagulopathy? So we can do few things. One is to start with, usually we start our resuscitation with fluid. So you have to have a balanced resuscitation, and then you start with the hemostatic resuscitation where you resuscitate patients with blood and blood products. To talk about this blood and blood products, so there has been like few ratios they have discussed. Most favorite one is like RBC plasma platelet 1:1:1, but there are some other strategies like 1:1:2 has been practicing in some other countries, but there are no they have not found any benefits in 1:1:1 versus 1:2 is like RBCs. So they have not found like special benefits. So most of the countries practice 1:1:1 ratio. This point of care testing of TEG and TEM has been an influential in managing this coagulopathy because that will give a good idea about what exact factors are deficient and what exact components need to be transferred. So this will reduce the amount of fluids going into the patient, amount of RBCs, amount of platelets, and so in turn that will cause reduction of the reaction as well. Place of calcium, still it's again in doubt. If patient has evidence of low calcium, you need to give calcium, but other than like you don't have like give prophylactic calcium in trauma resuscitation. But if you find the calcium levels are low, you need to give calcium for the resuscitation. And the other one is the tranexamic acid. Yes, so there has been some trials, CRASH 2 and 3 trials has proven, and of course for this one again there are different thoughts. Some people does not believe it has a benefit, but most of these trials have proven tranexamic acid has a place in managing coagulation. So the best, it is given within first 3 hours 1 gram over 10 minutes, and then start with 1 gram over 8 hours as an infusion. So once we manage the damage, the coagulopathy, we are going into the concept of damage control resuscitation. So this is not a new concept. This has been introduced to the medical field from military concept or naval concept, where some other ships from United US Army, when they were like hit in the middle of the sea, how to get the ship into a shore or to a harbor without getting into trouble. So that has been introduced to the medical field. So damage control is important because the most of the deaths are due to hemorrhages. So it's a systematic approach to manage the trauma patients with severe injuries, and it emphasizes on restoration of the physiology rather than the anatomy. And it believes the first form clot is the most stable clot. So you don't need to pop that first clot. And the damage control resuscitation should start at the scene of injury and should go through the emergency department and then to the operation theater and to the ICU. So there are few steps or few strategies they are using. One is hypotensive resuscitation, where you don't achieve normal blood pressure in these patients to reduce the amount of risk of bleeding. And also they practice hemostatic resuscitation, where that encourages you to start blood and blood products very early in your resuscitation. And then they encourage the damage control surgeries, where the primary objective is to control the hemorrhage and contain the spillage, and no anatomical corrections are attempted, and they are very brief surgeries. Once you do that surgery, patient will resuscitate in ICU setup. Once you resuscitate, go for corrective surgery. So that is what they are encouraging in damage control resuscitation. So to start with our fluid management, so you need to replace the fluid and get the blood pressure up, and to improve the perfusion and organ function. So you will have a safe level of blood pressure to maintain the tissue perfusion until your primary problem is sorted. So initially they have talked about two ways in fluid resuscitation. One is the aggressive fluid resuscitation, where you restore the normal blood pressure, but there are some advantages. The disadvantage they have noticed is, so you can pop that stable clot and then it can lead into bleeding further. And then this is the method in damage control they are following, is permissive hypertension. It maintains the organ perfusion without going for normal blood pressure. So the targets of mean arterial pressure in damage control resuscitation is lower than the normal. So usually MAP is about 55. Our normal MAP we are trying to maintain is about 65, and the systolic blood pressure target is about 80 to 90, not 100, 110. But the problem is, if patient is having a multi-trauma with concurrent head injury, you cannot maintain this one, because you have to maintain the cerebral perfusion, where you need to maintain normal or more than normal mean arterial pressure. So it should be around 80, and systolic blood pressure should be above 100 millimeter mercuries. Right, so those are the concepts in damage control, and then we have to think about what fluids you need to give. So the discussion has been there whether there's any ideal fluid which should be like similar to ECF, should remain in intravascular and safe, no toxicity, cost effective, but it is not available. So we don't have it. So we are left with whether we have to start with crystalloids. But the problem wise, yes, when you infuse a lot of crystalloids, you can have some problems like dilutional coagulopathy, metabolic acidosis. So we have restricted the maximum amount of crystalloid into 1 liter. And then the benefits of crystalloids are there. So it is low cost, less adverse effects, and good in resuscitation with either any patient with like TBI. And there has been some discussions whether to start colloids, but most of the researchers found that colloids are not there are no overt benefits with crystalloids and colloids, but when it comes to the head injury, colloids has some adverse effects and more side effects. That's why to start crystalloid resuscitation in these patients without going for colloids. And there have been some discussion what crystalloids to be started, either normal saline or balanced crystalloid like Hartmann's. And then to talk about these, researchers are not primarily on trauma, but in critically ill patients. But they have found there are slight benefits in managing patients with balanced crystalloids. Like there are advantages of balanced crystalloids over normal saline. But when it comes to again head injuries, balanced crystalloids, because Hartmann contains some bicarbonates lactate, so that is not beneficial to resuscitate with normal saline in that same case. So once we start the fluids, the maximum will be about 1 liter, and then we need to go for blood and blood products. So this is one of the protocols that we have to apply daily, the massive transfusion protocol. According to the definition, there are a few definitions, but in emergency setting, we cannot take these retrospective definitions. We usually go for like replacement of 50% of total volume in 3 hours, or any rate loss of more than 150 ml per minute blood loss. You need to activate, so it's a massive transfusion, so you need to activate massive transfusion according to these things. So there are number of scoring systems to predict. So when you receive a patient, so if patient has these parameters in patients, so you need to activate the massive transfusion protocol. Usual in our setting, we use this ABC score. So if you have 2 or more than that of these numbers, we tend to start massive transfusion protocol. So once you start massive transfusion protocol, the blood bank will send you like boxes, and then so depending on the availability of point of care testing like TEG and TEM, you can like change some of the things according to the deficiencies of this patient. So once you are continuing the massive transfusion, so you need to see whether you can maintain some of these parameters in this patient, like temperature maintenance to prevent hypothermia, because those things are killers, as we discussed earlier. And then the pH should be like maintained more than 7.2, and calcium about 1, and then the platelet and fibrinogen. So when you are transfusing, so if you can maintain this sort of thing, and if you can continue this one, so patient's coagulopathy will be dealt in a good way. So once you start your blood transfusion, and when you detect this patient as evidence of bleeding, you need to send this patient to the operating theater to contain that hemorrhage and contain that spillage. So you cannot maintain, like, you cannot continue damage control resuscitation without attempting to the primary cause. So patient won't, like, you cannot send this patient to ICU for like next 24 or something like that, because you don't maintain normal blood pressure to maintain the organ perfusion. So you need to act to the primary problem. Now the patient should go to the theater for damage control surgery. So these patients, because the reserves are very low, it should be very short time in short surgeries. I think it's according to the maximum time will be like about 90 minutes. And then should focus on controlling the hemorrhage, contain spillage, and maintaining the blood pressures. And then there are different strategies you can use to, like packing, fibrin sealing. And what they discuss is you don't even have to like close the abdomen primarily. So you can open the abdomen to prevent the abdominal compartment syndrome. And then once you do that, you have to move the patient to ICU for further resuscitation. So then once you resuscitate, once you again control the lethal triad, you can get the patient and to do the definitive surgery in due course. So this is what I was intended to do. And then so I think these are the things again I'm emphasizing as a take-home message. Most of the trauma, major traumas, are time critical, and then you have to have a very good team. So there should be a team for good outcome, and then you have to treat the killers, especially acidosis, hypothermia, and coagulopathy, out of which the coagulopathy is the one. So you have to treat the other things to control the coagulopathy. So in a trauma situations, so you can have a combined decision whether you can go ahead with damage control resuscitation. You can do it for the torso trauma without having any head injury. And then we need to reassess these patients frequently to identify what factors went wrong again, and then treat accordingly. And then when you are dispatching this patient, it should be appropriate and coordinated to have a best outcome. Thank you.
Thank you very much, Duminda, for that lecture. Now, question time. Any questions from the audience?
What do you think about the fluid switching? Sometimes the fluids are stored in a cold environment in the hospital. So administration of IV fluids which are...
Yes, that's one of the questions we have been having for so long. Even in the ETU, we don't have a fluid warmer. When it comes we had to activate massive transfusion at least once a week or something like that. But when we are trying to give fluids, we give cold fluids. So we, of course, probably we would have seen a lot of things happening, even in the ETU, we might see started bleeding or something like that. So we do very crude methods, we get hot water and then infuse this thing. So I think it's better. I think in Madam theater setting you have a fluid warmers, isn't it? But in but not functioning, Madam, right now. Yes. So we have we have asked, but we couldn't get these things organized until now. I think that is one of the important things. For the peripheral hospitals, what we have seen is infusing 4 liters of normal saline is not very uncommon in this practice. So what we advise is, with the second pint, if you find the blood pressure is not maintained, either you have to transfer to a place where you have blood and blood products, or to start, if you are in a place where blood is available, start bloods, and it won't harm a patient. That is my experience, and others also can comment. Madam, sorry. Yes. Yeah.
Any other questions for the audience?